So I'd now like to hand over to Associate Professor Yoland Antill. Thanks, Yoland.
Thanks, Vanessa, and thank you to Marion. It's always nice going second because usually the speakers prior to me will set the stage beautifully for where I'm going to move into. So I'm going to talk tonight about how we might use genetics to guide treatments. Ooh. Providing I can work the slides. So Marion has already described beautifully the difference between familial and tumour mutations. So the familial or hereditary mutations are ones found in the egg or the sperm that are passed by hereditary to the offspring, and they're present in all cells. And this results in heritable conditions such as an increased risk for cancer, in particular ovarian cancer we're focusing on here tonight. Somatic or tumour mutations are present within the tumour cells themselves. They can reproduce the abnormality within the cells within the tumour, but they are not heritable from generation to generation. So non-hereditary genetic changes occur in ovarian cancers as they do in all cancers. These genetic changes can be what we call somatic, so they're acquired changes within the genetic code of tumour cells, and it impacts that normal function of the gene. When someone talks about something being clonal, it means that as the cells reproduce within the tumour, as the tumour cells grow and divide to make new cells, those same mutations are present. But generally, as a tumour has been there for a longer period of time and the more generations of cells or the more cells that are produced within the tumour, the more mutations are acquired within the tumour itself. A tumour can also have a gene that's silenced. This is called methylation. When an active chemical process starts or impacts the beginning part of the gene to stop it being read from beginning to end. It's like closing the book on the start of your recipe. It stops that gene from functioning normally. And again, within the tumour, methylation impact on one cell can occur in the generation of cells below that. Methylation can be hereditary, but it is a very, very rare condition. And then we're also going to focus on this concept called homologous recombination deficiency, or HRD. So hereditary ovarian or ovarian-like cancers, so just to remind you, as Marion has said, when we're talking about ovarian cancers, we're including tumours that have arisen from the ovary, tumours that have arisen from the fallopian tubes, or tumours that have arisen from the blanket covering of the abdominal cavity known as the peritoneum or primary peritoneal cancer. So hereditary ovarian cancers are associated with genes that Marion has already run through. The most common of the genes associated with hereditary ovarian cancer are BRCA1 and BRCA2. There are other genes that are involved in double-strand break repair or homologous recombination repair, and they're those ones known as RAD51C and D, BRIP, potentially ATM and CHEK2. We then also have those mismatch repair genes, the Lynch genes, that make up around 10 to 15% of hereditary ovarian cancer. And as Marion has described, the Lee-Fraumeni syndrome, or a very rare condition associated usually with very young onset ovarian cancer in a gene known as TP53. The Walsh paper on the side was published a number of years ago and demonstrates, again, a similar spread of the genes that we've described. And there are a large number of studies now that have been published looking at nationwide or multinational collections of women who've experienced ovarian or ovarian-like cancer, and the breakdown of the genes contributing to ovarian cancer risk is very similar. This includes the Australian Ovarian Cancer Study. So homologous recombination recombination is an important pathway of the way repair is enabled when damage occurs in that genetic code. So DNA, the chemical, remember, that tells our cells how to work and behave, is constantly being damaged and repairs itself within our body to create a perfect copy of that genetic code in the generations of cells beyond that first cell. So when DNA is repaired, the process is called homologous recombination. Homologous recombination deficiency is when the body is unable to repair those double-strand breaks. And it means that the cancer cells have a harder time repairing themselves, and people whose tumours are associated with what we call homologous recombination deficiency may have a greater sensitivity to certain treatment types. And we'll go into that in the next couple of slides. Originally, it was felt that BRCA1 and BRCA2 were the only genes associated with this condition known as homologous recombination deficiency. But we know now that there are other genes associated within this pathway. So homologous recombination deficiency is a state associated with an alteration in one of the genes that is associated with DNA double-strand repair. So this can either occur because of a hereditary change in one of those genes, or if the change has occurred in that tumor, in those tumor cells themselves, either as a somatic change or as silenced by methylation. We know that BRCA1 and BRCA2 associated ovarian or ovarian-like cancers have a greater likelihood of response to carboplatin-based chemotherapy. We also know that BRCA1 and BRCA2 related ovarian cancers have an ongoing or a greater likelihood of ongoing response to platinum therapies. So platinum would be the first-line choice in the early ovarian cancer setting aimed at cure. But if an ovarian cancer relapses, particularly for those BRCA1 and 2 carriers, we would offer generally platinum as second, but often those tumours respond again and again and again to platinum-based chemotherapies before resistance would occur. We know that, in fact, homologous recombination deficient tumours are more likely also to respond to platinum-based therapies and will perhaps respond again in that relapse setting and perhaps have prolonged platinum sensitivity compared to those homologous recombination proficient tumours. We also know from the SOLO-1 and the SOLO-2 trials that once chemotherapy has been given, if we maintain the effect of that platinum-based therapy with a PARP inhibitor known as olaparib, that it reduces the risks of recurrence or relapse again of that ovarian cancer. So these graphs that we've got here are what we know as Kaplan-Meier curves. You don't need to remember the names of that. It was a clever person who designed the way of statistically analysing whether a treatment responds or does not respond to a tumour. So if we look at these two curves, every time the line drops down, it means that a tumour is no longer responding to the treatment. In this case, the treatment is olaparib. So this was a trial looking at first-line maintenance therapy. So this means that women have been diagnosed with ovarian cancer and they've received treatment for the first time. And on the completion of their chemotherapy, they were randomised to receive either olaparib or a dummy drug. And you can see very clearly that even within 3 months, these curves start to separate. And there are fewer women whose tumours relapsed who received olaparib compared to those women who received a dummy drug. Similarly, in the relapse setting, So these are women whose cancers unfortunately have returned. There was a study that again looked at the comparison of olaparib with a dummy drug, and again, following chemotherapy with platinum, you can see that within a few months that the women who were receiving the olaparib had a lower chance of their tumours relapsing again than those women who received the dummy drug. A very wise person once told me that if you can drive a pencil between the lines of the curve on these studies, then it means you've got a treatment that works well. So we know now that in Australia, if you are a carrier of a BRCA1 or a BRCA2 mutation, either within your tumour, so a somatic mutation, or as a hereditary change, you are eligible to receive olaparib following your first-line treatment. And if you continue to have a tumour that is sensitive to platinum in the relapsed setting, if your cancer returns, then you would be offered olaparib as maintenance therapy at relapse. So more recently, and particularly as we know now that BRCA1 and BRCA2 are not the only genes that contribute to this condition known as homologous recombination deficiency, the PRIMA trial looking at niraparib maintenance, and again, there are two trials looking at niraparib, both in the relapsed setting and in the first-line setting, and I've just looked at or put up the picture here of these curves for the first-line setting. You can see that in all women with homologous recombination deficient tumours, and about half of the total number of patients had homologous recombination deficient tumours, you could see a very significant difference again with fewer tumours relapsing if they were given niraparib versus those who received the dummy drug. Again, these curves start to separate out at around about that 3-month time period. If we look over here, though, at this particular graph, you can see that even the tumours that were homologous recombination proficient, so this dotted line here represents the line that suggests whether a tumour group will respond or not respond. And if you're on the left-hand side of the curve, you're a responder. If you're on the right-hand side of the curve, you're a non-responder. If you cross the line, then it's not really a statistically significant finding, but you can see that the homologous recombination proficient tumour group, albeit a small group, they still received a benefit from niraparib maintenance therapy. So currently, we know that women can receive niraparib access via an access program, but it's not all women with high-grade epithelial ovarian cancer, and that reflects the women who were recruited onto the PRIMA study. So women who had high grade, and that represents grade 2 or grade 3, epithelial serous ovarian cancer and epithelial endometrioid cancer, regardless of their BRCA status, are eligible to receive niraparib via the access program. That means at no cost to that patient. I have put here the outcomes of some of the side effects that can occur when you are on either olaparib or niraparib. And we know that there are differences in side effects between olaparib and niraparib, and certainly compared to a dummy drug. There are side effects that we would expect with both olaparib and niraparib, particularly differentiating a risk of blood pressure, increased blood pressure with niraparib, and a greater likelihood of things like thrombocytopenia, and nausea with and fatigue with Niraparib compared to Olaparib. So while these medications are available for use, they can cause side effects, and you may need a dose reduction if you're receiving Niraparib. So it's important to tell your medical oncologist if you are experiencing side effects if you are on maintenance therapy, because we know that a significant proportion of patients, both on the SOLO-1 and SOLO-2 trials, so they are the Olaparib PARP inhibitor trials for BRCA1 and BRCA2 carriers, and an even greater proportion of patients on the PRIMA and NOVA studies looking at Niraparib in the relapsed and first-line setting, experienced side effects that needed them to reduce the dose of the medication, but patients' tumours still responded to those lower doses. So don't ever be shy or keep to yourself any side effects that you might be experiencing, because a dose reduction does not mean a lower risk of responding to the therapy. I'm going to move now to the ovarian cancers that might be associated with mismatch repair deficiency or the Lynch syndrome genes. So in recent times, we know that the expansion of immune therapy with treatments known as immune checkpoint inhibitor therapy has expanded and is of particular interest in cancers that relate to mismatch repair deficiency. In general, these are cancers that have a really strong interest or a tie-in to the body's immune system. And we know that using single-agent immune therapies has a very high likelihood of response to immune checkpoint inhibitors if, in fact, they have this condition or state known as mismatch repair deficiency. In ovarian cancers, the vast majority of ovarian cancers associated with mismatch repair deficiency are of endometrioid histology. They are often associated with endometriosis, but may in fact represent the small proportion of ovarian cancers that occur in very young women. So if we have an endometrioid, in particular ovarian cancer, we would often ask our pathologist to do this preliminary test that Marion described, looking to see if mismatch repair deficiency might be implied in the setting of that ovarian cancer. Just like BRCA1 and BRCA2, mismatch repair mutations can occur either as hereditary change or within the tumour themselves. But response to immune checkpoint inhibitor therapy can occur either because of that hereditary change or because of the changes within the tumour cells themselves. So even though, as Marion said, the mismatch repair genes may be part of an ovarian cancer gene test, if an ovarian cancer relapses, it would be important to consider that mismatch repair expression testing on the tumour to understand whether immune checkpoint inhibitor therapy may be an important treatment to consider in the setting of that relapsed ovarian cancer. So testing for hereditary ovarian cancer is still important, even though many more women can now access PARP inhibitors in the maintenance setting, as if a genetic alteration or what is known as a pathogenic variant is identified, the results individuals may, of course, impact the management for long-term ovarian cancer via access to PARP inhibitors, in particular Olaparib in comparison to Niraparib. But remembering now, if we go back to our slide of the SOLO-1 trials, nearly 50% of our patients who were diagnosed with ovarian cancer in the setting of BRCA1 and 2 are now surviving their ovarian cancer diagnosis. So while in the past we hadn't really focused on the other cancer risks that might be associated with that particular gene, For those women, managing those other cancer risks are now very important. Of course, managing and testing for other family members is just as important if a hereditary change is identified. Gene testing, as Marion described, is largely a funded option if the chance of an abnormal ovarian cancer gene is greater than 10%. And this occurs in most epithelial ovarian cancers. Testing can either be done through a traditional family cancer centre referral or through your own medical oncology or your gynaecology oncologist through a process known as mainstream testing. Remembering that the risks of other cancer types with some of these genes is also increased. And Marion's touched on this. So if we look at the BRCA1 and BRCA2, we can see that breast cancer risk is significantly increased, as it is for PALB2. If we look at Lynch syndrome, we know that yes, ovarian cancer is greatest risk, but so too is a bowel cancer risk. Ordinarily, if someone is diagnosed with ovarian cancer, the original surgery would involve removal of the uterus as part of their surgery for their ovarian cancer. So the risk for uterine cancer that would be associated with Lynch syndrome is actually removed as a result of their original surgery. There are smaller risks for other cancers, in particular for males, including prostate cancer and pancreatic cancer. And I haven't mentioned some of the more rare genes like ATM, RAD51C and RAD51D and BRIP, but certainly as more is known about the genes that are associated with ovarian cancer risk and more is known about the other cancer types that may be associated with the more recently identified genes. So in summary, genetic changes, either hereditary or within the tumour, can predict increased response to certain types of therapies. BRCA1 and BRCA2 have prolonged and repeated responses to platinum therapy and derive benefit from the use of olaparib maintenance. In particular, HRD-related tumours have increased sensitivity to PARP inhibition and have access now in Australia to Niraparib, and mismatch repair deficient tumours may be associated with an increased likelihood of response to immune checkpoint inhibitor therapies. Testing for these hereditary genes is still important to understand the potential risks for other cancers in the individual, but also understanding whether other family members will also be at increased risk of cancers and what they might do to prevent or manage that cancer risk. Thanks, Vanessa. Back to you.
Wow, thank you so much, Yoland. So much valuable information in that presentation. We've had a lot of questions come through, so I do apologise if we don't have your question answered. I am conscious of time, so we'll just go with two questions. The first one is, can ovarian cancer skip a generation? My mother died of ovarian cancer in 1967, and I have two daughters. She says I don't have the BRCA gene.
That's a really interesting question. Oh, did you want me to answer that, or did
yes,
you want
please.
Marion to answer that? Okay, I'll answer that. So the risk of a cancer is not 100% for these genes. And so particularly if a genetic change is being passed from a father or through a father to a daughter, it can seemingly miss a generation. The risk for ovarian cancer for BRCA2 in particular can really vary from family to family, from around 10% risk to as high as 70 or even 80% risk. So it can seemingly miss a generation, but the actual genetic change is passed from mother to daughter or father to daughter or mother to son or father to son, and then generation on from that. So the actual genetic change doesn't skip a generation, but the risk for cancers is different from individual to individual.
Thank you. And one last question. What is the difference between olaparib and niraparib? I don't understand why one is used instead of the other.
So they are different. They're both PARP inhibitors. Niraparib is thought to have greater potency, so it's a more complete blockade of the way PARP works in homologous recombination repair. And it's possibly also why there are more side effects associated with niraparib use than olaparib. If you are a BRCA1 or a BRCA2 carrier, or the tumour has BRCA1 or BRCA2 alteration, we know that olaparib is an effective way of maintaining the effect of the original cancer. But we don't have the same confidence that olaparib will work in all HRD and particularly a homologous recombination proficient cancers. So at the moment in Australia, unless you have a BRCA1 or a BRCA2 gene change, either hereditary or within the tumour, then olaparib is not available for use for maintaining the effect of your chemotherapy, but recently available is now niraparib.
Great, thank you for clearing that up. Thank you again very much, Yoland, for joining us on this webinar. We will now move to our final speaker, Christine Christie.